Hello and welcome to the Liverpool School of Tropical Medicine In Conversation podcast. I'm Russell Stothard, Professor of Medical Parasitology here at the Liverpool School of Tropical Medicine, where my work focuses mainly on neglected tropical diseases, especially schistosomiasis. Schistosomiasis is a worm-related infection, and it brings together schistosome parasites, people who are infected, as well as animals that can be infected with this parasite, as well as the aquatic environment where you find the larval stages of the parasite. Today's conversation, we're exploring an aspect of schistosomiasis through a woman's health and research lens, because we're going to be focusing on female genital schistosomiasis, or FGS, as it's more conveniently known. We're going to see how it links to broader health system outcomes and also gaps, and what it means for how we design research and also the surveillance of female genital schistosomiasis, and looking forward to future targets to reduce it throughout many parts of Africa. So I'm really fortunate today to be joined by my PhD student, Ayesha Bell-Gamwoto. She's from Liberia, and she's studying in the LSTM. She's been doing field work in Liberia and also molecular work here at the Liverpool School. And she's very much focused on women's health, with focus on female genital schistosomiasis, as well as its wider impact on their livelihoods. So she brings a wealth of experience, which is honed over an undergraduate as well as a master's degree. And also she's been working in Liberia for several years. We're going to hear about a story in a second. So we're going to be discussing what her research is revealing, the realities of working in endemic settings such as Liberia, and why we're looking forward to integrate gender into community health and also One Health perspectives to really show how we're going to tackle schistosomiasis. And this is really kind of following the World Health Organization's roadmap for control of schistosomiasis, which has got a vision to eliminate it as a public health problem, as well as interruption of transmission. So, Ayesha, tell us a little bit about your journey into tropical medicine and the PhD research you're doing, and what really attracted you to schistosomiasis at the start?
Well, thank you for having me, Professor Stothard. I've had an interesting journey, and I'll just summarize it. So I just found myself very fortunate that as a child who went through the war in Liberia, I was able to have an education, and I always promised myself that I will go back to have an impact and to do something there, especially for the women and girls. And I was interested in medical sciences. During my undergraduate degree in biomedical science, I had an internship in Ghana, and where I worked with a team from Johns Hopkins University, and they did work in a village in Ghana on schistosomiasis, urogenital schistosomiasis. We looked at the calcification of the bladder from several young girls in that village, and I found the topic very interesting at the time. So years later, when I came across your work, Professor Stothard, on schisto, I was very interested in that, and especially female genital schistosomiasis, because due to Liberia being a post-war country, and we have the lack of healthcare evidence-based data for us to implement policies, I thought it was very important for us to have FGS surveillance in Liberia, and especially for the benefit of the women and the girls in the country, that they're screened for this awful disease.
Thanks for that, Ayesha. I suppose I'll tell you a bit about my journey in Liberia, because that started off in 2010, because Liverpool School was involved in National Control Programme for schistosomiasis. And during that time, there was a lot of emphasis on treatment of disease in children. But sadly, because of stretched resources, there wasn't enough skills base and also resources to tackle the bigger problem, which is how adult women are affected by female genital schistosomiasis. And there's a little backdrop, because it's a kind of career aspiration. You remember that Dr. Louise Capoto, who was very influential 10 years ago, is now the Minister of Health, and she was PhD student at the Liverpool School of Tropical Medicine. So it's highly likely that hopefully in the next 10 or so years, Ayesha, you'll be able to kind of give back to Liberia and also to raise the profile of the disease. So tell me a bit more about your aspirations of what you hope to achieve, let's say, during your PhD research.
Well, during my PhD research, I hope to produce data that will inform healthcare policies which could be implemented throughout the country. Because one of the problems that we have, like I said, is, we don't have evidence-based policies in Liberia. So what we wanted to do really was to put together information on FGS in Liberia, gather molecular information within endemic counties within Liberia, and to screen those populations of women in those endemic counties to see the weight of the problem of schistose. So, for example, for my PhD research, we screened 400 women, 100 women from 4 endemic counties in Liberia, Nimba, Bong, Lofa, and Maryland. And we did urinary analysis, a microscopic analysis. We put together a questionnaire that had both public health and clinical information where we screened them. We also had gynecological examination. And we also did molecular work where we looked at their swab samples for schistose DNA. So, that was all part of the work that we did there.
No, I'm really proud because, as a female scientist working in Liberia, not only have you made an impact on the ground already, but you've also written up the research in special issue of parasitology, which I was very fortunate to edit. We brought together a bit of a broader perspective on female genital schistosomiasis in Africa and also male genital schistosomiasis. We're not going to talk about male genital schistosomiasis so much. We'll keep more focused on the female genital schistosomiasis. But, looking back in Liberia, and we think of the fragility of the health system and the surveillance on the ground, what challenges do you overcome and how did you manage to kind of coordinate that? Because it is a difficult thing to do, Ayesha, as what you've done, you've been successful. But for the people that are listening to this podcast, paint them a picture of what the service of like primary healthcare is in these counties that you did this FGS surveillance.
So first of all, if we have to look at the context of these countries. So Liberia, like many sub-Saharan African countries, are not mono-ethnic nations. So what do I mean by that? As in within a country, you've got many different groups of people, many different languages, many different beliefs, cultural beliefs. It's not like in England, for example, we know most people speak English, and you can also assume a certain amount of literacy, for example, within the country, whereas in countries like Liberia, that's not the case. So you already have that, even in countries that haven't had conflict within sub-Saharan Africa. So you already have that against a backdrop of a country that has had post-war conflict. So you can imagine, so post-war Liberia, we've got a lack of infrastructure, both in terms of structure and human resource. There's a lack of that. So these facilities have next to nothing in them. So not only do you not have things like a colposcope in these facilities that's normally used to help with FGS diagnosis, but even the personnel that's involved, are very few. So that was one of the reasons why when I designed my research, I was so keen on designing it in a way that was applicable to the setting. So I was focused on using a speculum rather than a colposcope because that was one more practical for that setting. The midwives there were able to use it. We should have had experience in using it for years. It doesn't require electricity. Most of these places don't have electricity, even within the healthcare centers. So you have all those different barriers there. So I had to design the research in the way that was applicable to those communities, to the people, and relevant for each community for them to be able to receive it. And I think anybody doing research in sub-Saharan Africa and countries like Liberia, they have to bear in mind that it's not a blanket approach. It has to be a tailored implementation for these communities, bearing in mind their diversity of ethnicity and culture, and the lack of infrastructure and human resource in these places.
No, I mean, you've done an excellent job, Yusha, because you're able to bring and maximize the resources that are there because of networking and the communications, but also looking forward, you brought samples for higher end analysis back to Liverpool to kind of scrutinize samples in greater detail. That's the other diseases which are associated with female genital schistosomiasis, such as human papillomavirus, which is incredibly important, as you know, for cervical cancer. If I just step back just a second, though, you know that across Africa, WHO is very interested in female genital schistosomiasis because it affects anything up to 56 million women. adult women as well as adolescent girls. Adolescent girls, of course, if they're not in school, they miss treatment for schistosomiasis. So, you highlighted that a lot of the girls aren't completing even secondary education. They're dropping out early, so they go under the radar. So with WHO, they're trying to embed FGS surveillance and control within the broader reproductive health. So looking at HIV, cervical cancers, other gynecological diseases. And I suppose that's a challenge in Liberia, is to say you have the evidence, so you'd be able to show that there are certain people that can be mobilized, midwives, to do cursory examinations. But when you think of like fully embedding that into like policies as well as practices, I understand in Liberia that they are starting to embrace more broadly now, stronger surveillance for genital tract disease in women. So tell me a bit more about what you know about those initiatives that are going on, building on what you've been doing at your PhD.
Yeah, so at the moment, like you said, you mentioned before, so our health minister has been very active, Dr. Louise Poto. She haven't been a gynecologist herself. We're really glad that she's taken up this cause and she's putting together a national policy for FGS in Liberia. And I'm working with the health ministry at the moment that the data for my research will be used within that national health, that national policy for FGS, which is a huge step for the country to have something like that in place. And we're just hoping, because having a policy in place is one thing, but then the implementation of it is something else. So with much of these challenges in sub-Saharan Africa, but it's a major step in the right direction. So we're hoping that having that roadmap in place will help us to have constructive disease surveillance for FGS in Liberia and urogenital schistosomiasis as a whole.
It's really, really important. I suppose my perspective from Liverpool School is I'm able to help in Liberia, but also cross-country initiatives. And then I've been delighted to be invited to sit on the WHO AFRA board, which is going to be specifically addressing urogenital schistosomiasis and tackling how they embed this across other countries in terms of, sexual reproductive services. So, for example, the first step is they're going to make this regional technical advisory group in Brazzaville, which is Republic of Congo, bringing together a variety of experts. Some of those might be midwives, some of them might be scientists, some of them might be, policymakers, but also to know how you raise and embed that, because it probably goes back to training. A lot of doctors or midwives in Liberia, after that post-conflict period, weren't that privileged to be, have a specialist education. So there's like curricular review that needs to get taken place, and also how to best utilize, people's skill sets. I mean, going back to your training, because, once you finish your PhD, it's going to be very special because you'll act as a beacon or a signpost to other scientists. But just thinking of, the universities like University of Monrovia or Cuddington and those type of things, it's kind of unifying their health education systems to be tailored to primary care, I guess. Have you got thoughts on that then?
Well, absolutely. Like I mentioned before, one of my desires was to do something to help the people in Liberia post-war. And one of the things that I did was to develop the biomedical science program at the University of Liberia. And I've been the coordinator of that. We've had 7 cohorts of graduates so far, so very proud of that. And so as I'm doing my research, because I developed the curriculum for that biomedical science program, so I'm thinking about implementing all of these things like FGS and things that are very more relevant to the setting of Liberia within our degree programs. A lot of our students after the biomedical science degree go on to do medicine. So in fact, I've got a few of my students that are graduating from medical school this month, and it's really important and key if they have these things embedded into their educational system, so that as they're graduating as doctors and as medical scientists, they are aware of these diseases that impact the country.
It's very true, because I think one of the things that Liverpool School can play a role is like they offer a diploma in tropical nursing. They also offer a diploma in tropical medicine and hygiene, which, you've taught on because you talk to the nurses, and you also, when I've been talking to the diploma in tropical medicine and hygiene, it's really important to welcome scientists and clinical practitioners from parts of Africa. We would like to see more people from Liberia to attend, but obviously that's, a difficult thing to arrange, financing and so forth. But we have been changing the curricula a bit in the UK to try and push, more visibility for female genital schistosomiasis, mainly because of the risk factor nature with HIV transmission, as well as cervical dysplasia, which, and again, that's a very big international initiative to reduce cervical cancers in women, through vaccination. But if they haven't got the understanding of some of the drivers, let's say the female genital schistosomiasis, then it gets overlooked. I mean, you tell me a bit more about that and what you're doing with some of the samples that you're analysing at the moment.
Well, as you know, Sub-Saharan Africa has the highest incidence rate and mortality rate for cervical cancer in the world.
I know it's quite shocking, and some of that's like the poor surveillance systems to draw to the international attention. Yeah, I mean, money is going to be well spent because there's a big burden of disease there which needs to be addressed.
Right. So, and as we know, there's been links between FGS and cervical cancer because FGS makes women more susceptible to the HPV virus. And what we did actually, so from my samples from Liberia, from the swab samples, I screened them for HPV, and we actually found quite a few positives.
And it's not just, positive, it's high risk.
It's high risk. So because we looked at strain 16 and 18, which we know that are the high risk strains for precursors for cervical cancer. And and we found quite a few women positive for those high risk strains. And we also even found women who were also positive for UGS and FGS were also co-infected with HPV. So that's a very interesting.
Well, it's a very important finding, Ayesha, because on the two aspects. One, because the evolution of schistosomiasis in that adolescent girl going up to an adolescent woman and her lifestyles, and then of course, if she's catching what is a sexually transmitted disease, the HPV infection, then there has to be some type of education and awareness around it, and also embracing when the vaccine is being rolled out, because I think they are starting vaccination for HPV in Liberia, aren't they?
So we haven't had a national vaccine rollout, but we have had a vaccine rollout in certain places within Liberia. So Gavi have done that. They started off with that, but again, it's not a national scheme put in place. But what we're hoping to do, and hopefully we've, been able to obtain from this research, is we'll be able to see that HPV is definitely a problem in Liberia.
Well, I think it's been exceptional. Your work has been very seminal in showing that there is this connection, and you've got data on the ground to show that it's not trivial. There's a sizable proportion. It's in double figures percentages, isn't it?
Oh, yes.
So it's clearly something that needs to be addressed. I suppose the challenge we have with schistosomiasis is we get pulled in so many different directions because, as you know, one of the things I do is pediatric schistosomiasis. So it's the very young children, the under fives, that get schistosomiasis. So at the same time, you can have the adult woman's needs. Obviously, that's very different to the very young child's needs. And with schistosomiasis, I'm afraid there often isn't enough resources to satisfy all dimensions. But I think clearly when we think of it in terms of the wider, maternal and child health, there has to be a strong focus on female genital schistosomiasis. And at the same time, that can act as an opportunity to try and address some of the pediatric under 5 schistosomiasis, because the mums and the children are always together.
Well, absolutely. And apart from that, so that's why sensitization is so important, and educating women about this area is so important, because of course, if women are educated about FGS, and we've also there's been studies looking at maternity, looking at maternity, gestational pregnancy, and FGS, and all of that. And if women are aware of FGS, they can, when they have their children, they know, oh, okay, maybe I have to be careful, with letting my child be in possible infested waters. I have to look at, these are the signs that I look out for in case that they are infected, so that they can, and this treatment available for it to get it treated early. So when we educate women, that is actually a preventative measure against pediatric schistosomiasis, I would say. Because
very much so. I mean, just to give a broader perspective, there's a donation of praziquantel from Merck, and having worked in Liberia with the National Control Program, they're well engaged for that delivery system, which is typically to school-aged children, and then spill over into adults if there's sufficient drug. But there's also pediatric formulation, which is soon to be deployed, and hopefully Liberia might be one of the countries that might take that up. So when we think of looking further forward with female genital schistosomiasis, we can't overlook the needs of their children who may or may not be infected as they're washing their children in the water bodies and they're getting infected, because it's a bit of a vicious cycle, really. Schistosomiasis, it starts early, has consequences in childhood, has long-term consequences in adulthood, and it does really kind of change people's life opportunities, because if you can't have children, for example, or you have difficulties in being able to gynecological pain and all the associated stigma around that, it's something that we need to work hard to address, isn't it, Ayesha?
Well, absolutely, and this might sound funny, but within African culture, sub-Saharan African culture in particular, if you say to a woman, "Oh, this might kill you," she would say, "Oh, well, something's going to kill me." But if you tell a woman, "Well, this will stop you from having children,"
it's got a lot of cultural aspects behind
a lot,
that.
seriously. And of course, we know FGS is linked to infertility. And even during the course of my research, we had a lady who had not she didn't have children for 8 years. She couldn't have a child. And after the study, and because we gave the participants treatments during the study as well, who were infected, and she got pregnant and she had a baby girl.
It's very good.
Good
Well, just so you know, because like 5 or 6 years ago, the Countdown research program, which was held at the school, which was working very closely with the ministry and the NTD department there, they really did explore some of those like mental health and psychosocial dimensions of what it means to not be able to have children if you're trying to have them. So if you're subfertile, and it's a really difficult life predicament to get at if you don't have access to treatment. So
especially within that cultural context, where especially within the rural areas of Liberia, where having a child is considered as it's everything that is concerned in the West or in the UK is like, okay, if somebody couldn't have children, yes, it's devastating, but first, there are other options available that can help them.
True.
Whereas there isn't, and there's the stigma concerning infertility is even more in that cultural context than it is here.
Very much so. In fact, this special issue of Parasitology that we're editing has got a couple of papers. One is like developing a social science agenda to kind of formalize what type of questions are best asked to certain communities, because every community is quite different. They've got different cultural legacies and histories and so forth. So we also work quite closely with Sight Savers in Nigeria as part of the Countdown program with colleagues like Dr. Laura Dean. And then in Nigeria, there was Akinola, who was very influential in moving forward, like the FGS scorecard, and then making that comparison between Nigeria and Liberia. But at the end of the day, it's individuals such as yourself that are passionate about researching and trying to have a policy and public health impact. That's kind of the thing that we have to value and treasure, which is really delighted that you've taken up this task. Ayesha, you're going to be busy over the next 6 months because you're going to be writing up bits of your work and then obviously thinking about the next stage. But you've been trying to mobilize some other networks, haven't you, in terms of talking to different agencies and so forth. Just tell me a little bit about what you would like to happen if you had your dream wish.
Oh, wow, that's a good question. So first of all, because I was also the regional coordinator for the regional reference labs in Liberia, and I was able to see the pure lack in diagnostic facilities across the board within the counties in Liberia. I would really like to develop training for those lab technicians to be able to better diagnose urogenital schistosomiasis. And I would really like to go more into looking at the links between cervical cancer and FGS. And perhaps even because we know that male genital schistosomiasis is also a problem, and we have data for that for female genital schistosomiasis. So it will be good to see the problem of male.
Well, I suppose if you kind of quantify that in terms of the epidemiology, so your vision might be to have, at least 70% of women regularly screened,
Yes,
for
absolutely.
FGS
Absolutely.
annually,
Yeah.
perhaps, or if they can't do an annual level every 2 or 3 years, and there has to be an investment from the ministry to be able to sustain that, and
Yeah.
it is quite a big ask. So your wish will come true, of course, but it might take a lot of work, though, Aisha.
Yeah, well, again, I think this is why that kind of tailored approach is so important, because I think if I was to say, oh, let's have within the policy that every single healthcare center in the interior must have a colposcope, I don't think that's realistic.
True.
So I think in terms of like budget, in terms of context, you have to be realistic in terms of your ask, in terms of what you're putting into policy to implement.
Yeah.
So I think
well, we do have that little article that you've written for Trends in Parasitology, which is currently in review, and that's with Dr. Baines, who was,
the
obviously,
former health minister
yeah,
for Liberia
as well.
with Ebola, yeah.
And I think those type of discussions do help to kind of think of like financial forecasting, because when we looked at it,
Yeah.
it was in like, say, £300,000 to kind of like do that annually. But if you're stretched, £300,000 is like £299,000 too much.
Right. Exactly so. Yeah.
And I suppose when you've got other, like, other kind of competing interests. So I think this is one of the reasons why WHO is really trying to embed, the knowledge of FGS into more routine services. And then hopefully over 5 or 10 years, that might become so routine that people think, it's going to be a regular activity.
Yes.
With Shista, it's always been a bit stop-start. We have like MDA, it stalls because of, COVID,
Yeah.
Ebola, all the other things that happen. So yeah, there's always different shocks that we have to overcome. But ultimately, people have to have that knowledge base to kind of make sure that forward-looking, they're addressing the health problems which are relevant to their countries, I guess.
Yes, and also I think we can see overlaps, and often now, because we have a global community where you have people who live in the UK who have links to endemic populations.
True.
Who go to travel there, and when they from holiday, or even you could have like a aid worker, you could have an NGO worker. I had a lady contact me because she was an aid worker and she went to swim in rivers in Uganda, and she said, oh, I think what I have is actually a UGS, I could possibly have FGS. So we have to remember not to just think about these diseases as diseases of the global south or sub-Saharan Africa, but actually, with the airplane now, people can travel to these areas, come back here and have them. And even, we can have populations here who have family links there, and they can come back and be living with us. So it's very important that we have healthcare workers here informed of this disease.
Very much so. I mean, I'll elaborate on that point a little bit more, because that conference that we organised on genital schistosomiasis really showed, for example, colleagues in Spain, when they're doing migrant health screening,
yes,
FGS is highly up in their radar now, and anything up to 40 to 60% of people just screened without symptoms have actually got female genital schistosomiasis, so they weren't aware of it. So I think in the UK, we used to think of like female genital schistosomiasis as being, something overseas, but it's not, because it is a lot of like travel-related infections as well as migrant health as well. So it's a really important aspect which we need to do better. Just to close a bit, to draw it on, our work that we've been doing in Malawi, which has also shown that some of the species of schistosomes can happily spend their life cycle in things like livestock. So it's a very difficult thing to explain to health professionals. Once you've educated them about female genital schistosomiasis, that's not just the end of the story. There's another aspect after that, which is like, if you've got parasites which are coming from livestock, which are infecting the snails, which are then infecting the people, which then give them female genital schistosomiasis, for them to understand that their genital tract infection has ultimately come from an animal. My word, we've got a work cut out for us to explain that, and also to kind of try to control it. But I suppose the good news is, from the molecular work you've done in Liberia, that zoonotic source doesn't seem to be there.
Yeah, so I didn't see anything of what we call, hybridization or any zoonotic sources in Liberia, which was positive. It gives us one less problem to think about.
True.
And I think the reason being is because in Liberia we're not a large cattle herding community as in other places in Eastern and Southeastern Africa. But however, we do border places like Guinea, so we've been in the north of Liberia, where they do have larger cattle herding communities. And it's really interesting because where places that border Guinea, like especially Nimba, that had the highest UGS rates, actually bordered with Guinea. So, there's nothing, because these cattle herders come into Liberia as well. So this is why surveillance is so important. So even though I wasn't able to find any hybridization now or cattle source infections, it doesn't mean that it's not possible in the future. So surveillance is really key for those communities coming into the country.
I'll be going to Cameroon to work on the other project, which is looking at the hybrids in Cameroon, in terms of, we know that there's a lot of hybrid schistosomes in cattle, and also we find anything up to like half the number of children have actually got these hybrid forms. But as you said, parts of Cameroon which are more arid, more cattle farming up in the north, that's probably where we'll find that those zoonotic inputs the most, rather than down in the south, which is not that far, in terms of latitude, to places like Monrovia, really, in terms of you think of Yaoundé and that kind of like more tropical belt rather than the Sahel. Good. Well, I think we've enjoyed our conversation, and I hope the people in the podcast have been able to glean something about schistosomiasis, and also the fascinating work that the school's been doing, for over a decade now in Liberia, and also supporting the careers of eminent scientists now, but also those in the future who'll probably make an impact on reducing inequalities and also promoting health, and what better to do to actually improve women's health as well as children's health. So I think there'll be one or two papers that we might append as links to this, the one that we talked about, Ayesha's paper on the FGS school card. So thank you very much, Ayesha, and thank you very much for listening, and we look forward to any correspondence you may wish to share with us by email.
Thank you very much, Professor Stothard, and thank you to our listeners.